Assalamu alaikum wa rahmatullahi wa barakatuh. I thank the Hassan for giving us the opportunity to present at this wonderful conference. And can we have the slide, please? So I'll be talking about Wilson disease today. In the interest of time, I will make it quick. So Wilson disease was first described by Dr. S.A. Kinner Wilson in 1912. Initially referred to as progressive lenticular degeneration because of the involvement of the lenticular nucleus in the basal ganglia. The first patient who was described by Dr. Wilson was a man who had both neurological and hepatological manifestations. Later on, the recognition of copper and its role in Wilson disease came into view. Quickly, I will describe the basic pathophysiology, which all of us know about it, but just a quick revision. We know that copper is an essential trace element for mitochondrial respiration. Absorption into the body starts from the gut using ATP7A protein, and it is then transported to the portal, circulation, and eventually into the liver. Some of this copper is lost into the urine by the kidneys, some by the sweat. In the liver, copper is transported into the hepatocytes via the CTR1 protein, and subsequently it is transferred to the trans-Golgi network where further processing is done. So this is where all the problem starts in Wilson disease. ATP7 gene on the long arm of chromosome 13, it encodes for a transmembrane copper protein carrier, ATPase2, which is responsible for transporting this copper into the Golgi network for further integration into the carrier proteins, and subsequently it is excreted into the serum, and secondly it is also excreted into the bile, and from the bile it is excreted from the gut into the feces and outside of the body. The rest of the copper is basically bound to cellular plasmin, which then circulates into the serum in the blood. So once we have a block or a dysfunctional ATP7B protein, copper starts to accumulate in the hepatocytes, accumulates in the lysosomes until they reach their full capacity, and eventually the lysosomes rupture. This rupture causes massive release of copper into the cytosol, thereby causing cell destruction, inflammation, and the liver manifestations that we see in Wilson disease. The rest of the copper which goes into the serum deposits in the brain, the eyes, the heart, and the rest of the muscles. So in the brain, it affects the basal ganglia, it affects the rest of the cells, causing the neuropsychiatric and neurovilson that we know of. In the muscle, it causes rhabdomyolysis, it causes renal tubulopathy, and in the bloodstream, it causes oxidative damage of the hemoglobin and the cell membrane, causing the red cells to rupture. Thereby, we see the hemolytic anemia, which is Coombs negative, classical of Wilson disease. I'll be presenting the data that we have about Wilson disease at King Faisal Specialist Hospital. So we did an automated search of all the patients who were labeled as Wilson disease, all the pediatric patients, mind you. This excludes the adult patients. We have included all the patients who were diagnosed as Wilson's in the pediatric age group less than 18 years of age. So we found 122 patients who were labeled as Wilson, out of which 19 patients underwent liver transplantation. And I will shift my focus to the transplanted patients. Out of these 19 patients, predominantly we had females, which accounted for almost 70% of the children. Now, coming along, concentrating on the children who underwent liver transplantation. This is at the x-axis we have the ages, and on the y-axis we have the number of patients who underwent liver transplantation. So we see that the youngest child that needed transplantation due to Wilson disease was 6 years old. It's interesting to note that almost 1/4 of the children who underwent liver transplantation were less than 10 years of age. And the remaining 75% underwent liver transplantation, they were diagnosed above 10 years of age. This is the table which shows the 19 patients that we had who underwent liver transplantation. Their presentation, 12 of the patients had acute liver failure, and actually acute and chronic liver failure. 3 of them had Wilson. Out of actually 2 had both hepatic and neuro manifestations. 1 only had purely neuropsychiatric Wilson disease. 3 of them had chronic liver disease. And out of the 12 who had acute liver failure, 5 of them had severe encephalopathy. The youngest patient who was transplanted was 6 years of age at the time of transplantation. So his presentation, from presentation till the time of transplant was 1 month. But mind you, many of these patients had been wandering around in other hospitals and then eventually referred to our hospital. So this is why we have 1 month. See, he was transplanted within days of presentation to King Faisal Hospital. This patient eventually, genetic testing had homozygous and a compound heterozygous mutation for Wilson disease. And we'll talk about the mutations later on as well. This patient, who was 13 years of age, presented. Now we have 2 families who were from abroad. They were not Saudi children. So this child was a Yemeni child who presented acutely, was admitted at 4 a.m. And I'm proud to say that at 4 a.m. she was admitted to the hospital, and the very next day at 2 a.m., within 24 hours of presentation, the child underwent transplantation. She was in the OR. And the reason why we had to proceed with transplantation so rapidly was that she had severe encephalitis, and we had a very narrow window for transplantation. Her transplantation was done, the donor was a brother who eventually, on later testing, turned out to be heterozygous for Wilson disease. So this is just 2 of the 19 patients whose donor has heterozygous for the same mutation for Wilson. So this is the same table. The child who was, again, the 6-month-old had an early presentation, has 2 mutations, both homozygous and heterozygous mutation for Wilson disease, and also has a mutation which gives you an increased risk for Alzheimer's disease. Similarly, we have another patient who was 12 years of age at the time of diagnosis, also has a similar mutation for Alzheimer's. The girl who was transplanted at 13 years of age has another mutation with PTRHD1, which is responsible for neurodevelopmental disorders and juvenile Parkinsonism. Even though it's a heterozygous mutation, and so far clinically she does not manifest any such symptoms, but it's interesting to note that in this subset and in this part of the world, with a very high rate of consanguinity, we have found multiple mutations in the same individual. So establishing diagnosis is always a challenge, especially if you have acute liver failure. So out of these 19 children, 15 of them had high urinary copper, 24 hours. We were not able to do the 24 hours in 2 of the children because of the time constraint and that they needed urgent liver transplantation. And in 2 individuals, it was normal. Genetic study was not done in all of the patients initially. So we have had 10 patients who have been reported positive for Wilson disease. Most of them are homozygous. 1 of them is a compound heterozygous. It's interesting to note that 2 of the patients were negative. But this may be because that we have a genotype which is not yet discovered. They had all the features of Wilson disease, all the biochemical markers, including positive Kayser-Fleischer rings. And 2 of the patients we did not have a result, or it's actually pending now. We've sent it later on, and we're waiting for the results. 4 of the patients had positive Kayser-Fleischer rings. The genetic testing, it's interesting to note that this is the frequency of the gene testing that we have. The number 5 listed is the most common mutation that we've seen in the patients who have undergone liver transplantation. Gene number 4 was previously a variant of unknown significance, but now has been classified as pathogenic mutation. This is one of the mutations which was found in the child who had both the homozygous and the heterozygous mutation. Other incidental mutations that we've discovered, the most common mutations that we have found in patients with Wilson disease is association with Alzheimer's disease. Although all the patients that we have 2 patients who have the same mutation, but fortunately they are heterozygous for Alzheimer's disease. The other mutation we found in 1 individual was a heterozygous mutation for fructose intolerance, and as I mentioned, the last mutation which is responsible for neurodevelopmental disorders. So amongst the donor, as I mentioned earlier, we have 2 patients whose donors were from the same family, and we had to proceed for liver transplantation because it was a fulminant liver failure with encephalopathy, giving us a very narrow margin for liver transplantation. Hence, we just screened the donors for Wilson disease, and we proceeded with transplantation since their screening test was negative. Later on, we found that they were heterozygous. So this was a brief data that we have on Wilson disease, and let me take the talk further and elaborate the challenges that we have in Wilson pediatrics. It's always a complex disease in terms of diagnosis when it comes to acute liver failure, because at that point in time, especially if you're having encephalopathy, you're challenged with time and you have a very narrow window for transplantation. Many of our patients had high IgG and they had positive autoimmune markers, and it actually mimics many other autoimmune hepatitis, non-alcoholic fatty liver disease especially, that we know that it's the much older population which is affected by Wilson, which may have the right differential for an FLD. Wild hepatitis, cryptogenic cirrhosis, and other forms of familial intrahepatic cholestasis. The phenotypic variability is vast in these patients. International studies have proven that the younger age group presents predominantly with hepatic disease, and the older children, they present with neuroWilson. In the end of the second decade and then the third decade, they present more with neuroWilson or combined hepatic and neuroWilson. The limitations of conventional markers like seroplasmin, which may be falsely low in malnutrition or nephrotic syndromes. 24-hour urinary copper is always a challenging test to make, especially in younger children in whom collection is next to impossible. Hepatic copper quantification is very invasive, which we tend to avoid, especially in acute liver failures. And it mimics many other cholestatic liver diseases, especially MDR3, which also has a significant amount of copper deposition in the liver. The age-dependent penetrance and genetic heterogeneity is very variable in Wilson disease. In the other non-transplanted patients that we have, which are so far stable, we have many individuals who are compound heterozygous. Even though we know that internationally in North America and Europe, we have more incidence of compound heterozygous mutations. However, it seems that in the Kingdom of Saudi Arabia, we predominantly have homozygous mutations. The long-term outcome and transplant considerations in Wilson disease, one of the main challenges is predicting the reversibility, especially if you have a child who has acute liver failure and you are challenged with the diagnosis to begin with. But if you have the preliminary tests which are suggestive of Wilson disease, then you might want to give that child a chance to chelation therapy and avoid transplantation. I personally believe that any day without transplantation is a lot better than with transplantation, because you need to avoid immunosuppression and everything. But then it comes down to the fact that you have to weigh the cons and benefits. So it's always a challenge, and hopefully in the next slides we will see if in the future we can have markers to predict whether we can avoid transplantation in these patients. And post-transplant neurological outcome is also a hot topic. There are many studies substantiating that, yes, there is improvement in neurological outcomes in Wilson disease, and some actually say there is no significant outcome. In our set of patients, 3 patients who have been transplanted, 2 of them have actually improved, and the third one remains to have almost the same symptoms. He hasn't deteriorated, but remains the same. Family screening and ethical challenges. So I know in the UAE they have started across the board genetic screening for all the individuals, which is not the case in Saudi as yet. But I am sure that the acceptance of genetic screening is improving in Saudi. The future perspective in management comes down to precision medicine approach. And could genotype guide therapy? Yes, we believe that we need to maintain a very good genotype-phenotype correlation and a registry for that. We have had in progressive familial intrahepatic cholestasis type 2, we have been doing that, and we have identified a few genes, especially one gene which is responsible for a very high risk of hepatocellular carcinoma. So in those patients, we don't wait for hepatic decompensation. We proceed with transplantation as soon as we see that alpha protein is high, or we have any markers on the ultrasound, even as infants. So I'm sure that in the future, we can build a phenotype-genotype correlation for these patients, which can, inshallah, hopefully guide the decision for medications and guide for transplantation. And yes, it has a very wide clinical heterogeneity. We need to screen index patients, the extended family, as Dr. Shagrani and the previous speakers mentioned. We prefer not to do a target gene mutation because of the compound heterozygous mutations that we see in the population, but do a whole exome sequencing instead. The long-term outcome that we have for our Wilson post-transplant patients is excellent. We have 100% graft survival and 0% mortality so far, alhamdulillah. Yes, we do have a few rejections and biliary strictures, but overall mortality is 0 and graft survival is 100%. And eventually, yes, we do need some of the specific genetic data that will need to be refined so that we can tweak our management for medical and transplantation in the future.